All right. We got the army of two. Okay. Good or bad?
Bad.
Bad. Yeah, not
Looks like there's good amount of hemorrhage, necrosis, hemorrhage.
hemorrhage, necro. Yes, definitely. Well, really,
All of it.
death, necrosis. Look at all
Yeah.
this. There's procedural hemorrhage for sure, but there probably is also hemorrhage,
Yeah.
but definitely necrosis.
Yeah, the whole epi is necrosed.
Why might things necrose?
Um,
Well, that's not so good. So something we might want to check. How's their inflammation? Is there a lot of inflammation around here?
no, not a lot of inflammation.
Yeah. So when you see a bunch of necrosis and not a lot of inflammation, what might we want to check?
Um, you might want to check the stratum corneum.
Well, there's not much corneum left here, but sure, we could check that. But why might there be so much death with so little inflammation? What what keeps things alive? Let's start there.
What keeps things alive? Blood vessels.
Ah,
Yeah. Oh, maybe the vessels are occluded.
maybe we should check our blood supply. I agree.
Okay. They look like they are definitely not functioning well.
Yeah.
They're thrombosed and
There's something around them too. A
yeah,
little like basophilic cuff.
yeah.
So if this is so much necrosis, what might you imagine this looks clinically?
Like an ulcer or
Yeah,
uh,
ulcer, but what else? But if you have all this frank necrosis ischemic with from ischemia,
I guess like it could be black.
black.
Yeah.
Yes, this is going to be black. So what kind of things can cause that
Oh,
type? Yeah.
wait. Um, oh, there's some purplish. Is this ecthyma gangrenosum?
Yes. Good. This is ecthyma. So
Yes.
this is the image to bring in mind. So this the vascular supply is compromised, and you get this basophilic cuffing of your vessels on HD. That's the classic picture, and this might very well be on either the core or the applied exam. Wink, wink, hint, hint, cough, cough. Anyway,
Yeah.
so what should we stain this with? We should probably stain it up for some infectious stains.
Yeah. So ecthyma gangrenosum is caused by Pseudomonas, um,
Which
which
is a
which is a bacteria,
what type? What type?
gram negative,
The gram negative.
and it's usually seen in
Gram negative what?
oh I don't know.
Is it a gram negative cockeye?
No, it's a gram negative diplo. No, not a diplococci. It's a gram negative rod.
Yeah.
Um, and
Gram negative rod.
it's usually seen in immunocompromised people.
Yeah, so you could do a gram stain. You can
Yes.
see Pseudomonas. Very good. What in the world happened here?
Okay, so here the epidermis is pretty hypertrophic.
Yeah,
Yeah, it's pretty hypertrophic, and there's also some clefting. I don't know if that's artifact or if
that
that's
probably is artifact.
yeah.
By the
Uh,
way, if you just saw this area, what might you be thinking about?
like psoriasis.
Yeah, you could think about that. But
Well, no,
they're very bulbous.
not with the stratum corneum, sorry. And they're not like regular. What would I be thinking about there? Like something like LSC or
It kind of
prurigo.
looks like a seb without pseudohorn cysts,
Okay, that too. Yep.
which is classically seen in.
Um, oh, a sub without
If
pseudohorns.
it's on like genital skin.
I don't know.
Seb without pseudohorn cysts on genital skin is
I actually don't know.
Condyloma acuminatum.
Oh, okay.
However, does this look like Condyloma acuminatum?
No, because it's
Oh.
not like, wouldn't you expect condyloma acuminata also to have like some viral changes in the
So yes, but oftentimes actually you don't actually they can look quite like this often. And sometimes you don't really see the viral changes in condyloma acuminatum. Actually, the best way is a gently papillated knuckle-like papillation, not finger-like papillation.
uh-huh.
Fingers papillated are warts, knuckle papillated for condyloma.
Oh, good to know. Okay.
Gently knuckle papillated pattern with it has an outline. If you could imagine if there were pseudohorn cysts here, you just call this a sab outright.
Yeah.
So it's like take the sab and without the pseudohorn cyst, it looks like a condyloma. So at the edge, it looks like condyloma, but this is way too much. This wouldn't look like any kind of condyloma.
Yeah.
Really. Well, it is a kind of condyloma, but what do we notice here?
There are some organisms in the stratum corneum of some sort.
Organisms?
They look kind of like, oh no, they're newts.
There are newts. There's a bunch of
I
newts
can
here.
really see. Yeah.
Okay.
So newts in the horn, with knuckle like changes.
Well, here it's more than knuckle-like changes.
Yeah.
Here it's pretty extensive. And here's more. Are there newts here or something else?
I feel like there's mixed infiltrate there.
Yeah, it's not like a whole back-to-back newts like we saw in the horn.
No, but there are definitely newts there, but it also looks like there are lymphs, maybe plasma cells.
Yeah, mostly lymphs and maybe plasma cells.
Yeah.
So we think of like pseudoepitheliomatous hyperplasia with pus, but it's not right because the pus is up here, not down here.
Right.
Hmm. And this is, what do you think this looked like clinically?
Like a big growth of some
Yeah,
sort.
like an
Yeah.
exophytic
Exophytic
papillomatous
growth.
growth.
Yeah.
So exophytic papillomatous growth, newts in the horn, lymphoplasmacytic infiltrate.
Yeah.
By the way,
Um,
what's your differential for newts in the horn?
newts in the horn is C-tips,
Uh-huh, which is?
Candida,
Mm-hmm,
tinea,
mm-hmm,
impetigo.
mm-hmm.
Um, so oh God, what's the P?
Psoriasis,
Psoriasis, right?
sebderm,
Subderm, and then
and
what's the rest? Syphilis.
syphilis. Which one
Is
do you
this
think
a
it is?
syphilitic chancre
It's
or a syphilitic
syphilitic,
something?
but does it look like a chancre?
No, a chancre would be like more ulcerated, I feel like.
Yeah.
Is it a syphilitic like growth of some sort? I don't know
Yes, it
what
is. There is a syphilis. What kind of syphilitic growths of some sorts do we know about?
uh condyloma acuminata.
Yeah, well, condyloma, not acuminatum, but
Condyloma, some sort of condyloma. I'm
yes,
forgetting.
condyloma. What's the secondary syphilitic condyloma?
Oh,
Yeah, lata.
Lada, right.
Condyloma lata.
Right, because it's comes later. That's how I remember it.
Oh, there we go. That's good.
Yeah. Hi Nick. Welcome to our session.
Hi.
And then there were three.
Yes. Okay, this will be a little better, I think. So it looks like there's some atrophy.
Yeah, definitely an atrophic epidermis
Yes. Atrophic epidermis
with an infiltrate made of.
made of EOs a little bit, I think. I thought I saw a few EOs.
See if we can get a clear view here.
They don't look like lymphs. They're not jet black.
Yeah, they're not.
Plasma cells?
Yeah,
So,
atrophic epidermis, the plasmacytic infiltrate.
like acrodermatitis chronica agatrophicans,
Yes, exactly. And what's that caused by?
Lyme.
Lyme.
And that's why they're plasma cells, right? Because it's
Yes, it's a spirochete.
a spirochete. Okay.
Okay.
And this.
This looks like syphilis.
Yes. Why does it look like syphilis?
Sexy, slender,
Sexy, slender, reedy. With
Yeah. with plasma cells.
With plasma cells. That's the classic giveaway for syphilis.
That syphilis looked more like syphilis than the other syphilis.
Yes, well, well, look,
Yeah,
they're two different manifestations of syphilis.
totally. Yeah.
This would be like the rash of
Yeah.
secondary syphilis, and this would be the condyloma of secondary syphilis, i.e. condyloma lata.
Okay, this is a subcorneal split
Subcorneal split, good
with neutrophilic infiltrate.
neutrophils.
Yeah. I don't see any EOs in there. Yeah. And I can just look for other organisms in the horn, which I don't really see. There's some spongiosis in the epi. With
So you have a discrete
a discrete pustule with
this
the
area.
neutrophilic infiltrate.
Some remnants of some old ones over here.
Yeah. And some spongiosis.
Okay.
Is this acute atopic dermatitis?
Well, so if it's atopic
Or
dermatitis,
sorry, impetigo.
bullous impetigo.
Yeah.
Now, they're not
I was
mutually
thinking
exclusive.
AD
You can
though,
get
because-
impetiginized eczema, and you can
Yeah.
certainly get bullous impetigo on top of eczema.
Yeah, that's what I was thinking.
But yes, this is your classical bullous impetigo. Here's another what?
Subcorneal split.
Subcorneal split. You got your Klingon keratinocytes. You know it's not an artifact. So, what's your differential for this? Unlike the last one, we don't have a lot of neutrophils in here.
Yeah, it's pretty there's not a lot of
There's not a lot of infiltrate here
kind of
either.
posse inflammatory.
Yeah, posse inflammatory not only in the bulla, but also there's not a lot of perivascular
In
infiltrate.
general, yeah. Staph scalded skin syndrome usually
Yes,
doesn't
staph
have
scalded
infiltrate.
skin.
Yeah.
Yes, and what is the toxin cleave?
Desmoglein 1.
Desmoglein 1, very good. Excellent. Okay.
Like a little pustule. Something.
Yeah, I mean it looks like there is a bunch of neutrophils in here.
Are we dealing with acral skin?
Well, we could be. There's something a little bit odd about this. It doesn't, I mean, yes, there are newts in here, but it looks like it's kind of
Looks like the
this
newts are like also spilling over into
spilling
little.
into here. This kind of looks more eosinophilic, like it's dying.
Yeah.
And remember, when we see sort of things like involving death, what do we always have to make sure we check?
The blood vessels,
Our blood supply,
which are compromised.
which are compromised. Yes.
Yes. It doesn't look like vasculitis though, because I don't see newts around.
No, it's not good. I agree. Not a vasculitis. But so when we see a vasculopathy.
Yeah.
So
So
what we have
Fabric
to,
deposition or some sort
yeah,
of
and what do we have to make sure we rule out when we see a vasculopathy?
connective tissue disease.
Really, what's going to kill the patient really quickly?
Oh,
Infections like septic emboli,
yes.
invasive fungi. Those are things that are going to that you could diagnose with the stain quickly and identify empirical treatment, sometimes faster than the microlab will be able to detect the organism. So in this case, this was a septic emboli.
In the thrombus.
In the thrombus. Yes, septic emboli.
Yeah.
You're a little bit low. Your mic volume's a little bit low, Dick.
Oh, I don't
have a hard
know.
time hearing you. I'll turn my volume up. Now it's already all the way up.
Maybe I'm covering it.
There we go. Now I
Oh,
can.
I think
Now
I,
I can hear you.
oh, I thought it was I thought my question was you're gonna see the organisms in the thrombus.
You can sometimes, and sometimes you can see organisms percolating out through the wall. Like in certain cases of angioinvasive fungi, you can see the fungi coming out from the lumen, out percolating through the vessel wall. You don't always see it, but you're lucky if you do. All right, what happened here?
Ooh.
Is that a follicle?
Yeah, because there's a hair shaft, right?
Oh, yes.
All
It
right.
looks like there's some desquamation of the inner root sheath too,
Oh no,
right?
Oh, like the.
no.
I mean, is this like a?
All right, I get the joke. It was a funny joke. That's in premature desquamation of the inner root sheet, so it must be CCCA, right?
Well,
Probably not.
probably not CCA, but does look like there's desquamation, right?
Well, it looks like there's an explosion, like a rupture.
This
It
is
looks like there's like all levels of this follicle look like it's infiltrated. It's highly inflamed. There's a bunch of neutrophils. These
Yeah.
are probably bacterial colonies. These very small
this was like
oxide.
a folliculitis or like a cyst.
Yeah, it's a bacterial
Terminal.
folliculitis that ruptured the follicle. The bacterial, the cocci here are actually quite small. They look around the size. Pattern?
Uh, Perivascular
Yeah, superficial perivascular, sure. Characterization of the infiltrate.
plasma cell.
Plasma cells. Okay. Characterization of the vessels. This can be a little challenging sometimes. There's a
It doesn't
finding
look like
here.
there's like neutrophilic debris or any like.
Yeah, there's not, yeah, so we don't really see a whole lot of that. Do you see this vessel, how this vessel is open?
Yeah.
What about this one? Not as much.
Close.
And do you see how these nuclei are pushing in, almost like hobnail, but not quite, and how the vessel's kind of swollen up
Yeah.
to the point where you might not even be sure where the vessel is in some of these sections? That's a finding described as endothelial swelling.
No.
What's endothelial swelling finding described as?
And was it LGV?
Classically, it's associated in one of the classical things we associate plasma cells with.
That's like the it's like endothelial swelling. Is that gamma like gamma 5 ray?
No, it's classically a finding in syphilis.
Oh.
Not specific. I'm sure
Another
there are other
syphilis.
syphilis. This is all. Notice we don't have the sexy slenderiti here. In fact, here we don't have. We have the interstitial infiltrate plasma cells and endothelial swelling. So endothelial swelling can be difficult. The key, what I find most helpful for endothelial swelling is to see areas where characteristically I expect there to be a vessel there, and it kind of looks like a vessel there, but I don't see any lumen. And the plasma cells are there too, which is helpful. But this was another case of secondary syphilis.
Ooh.
They don't always give you the classic Reedy finding. So like here, I expect there to be a vessel here, but I don't see any lumen. I think I showed this already at some point.
This looks like I mean, on low power, it looked like a pilar cyst, but now I can see it's not. Lymphoid aggregates, is this a
Surrounding what?
surrounding,
Like granulomas.
Granulomas. We call that, and they're dressed up,
Eating granulomas.
tuberculoid
Oh,
granulomas
okay.
with what kind of necrosis? Where it's like this and it's chunking
Caseous
out, and
necrosis.
caseous necrosis. So what do we think?
Uh,
Maybe?
Familiaris disseminata faciae.
In lupus miliaris disseminatus faciae, is the caseous necrosis an area like this large?
No, it's more like circumscribed.
Yeah. So instead, let's think more simple.
Tuberculosis.
Cutaneous tuberculosis. More of what? What finding? What necrosis?
Caseous.
Caseous necrosis with a bunch of plasma cells. And up top, we have what's going on up top. Any findings around the follicles? Let's see, like here.
Some infiltrate.
Yeah, and like perifolliculitis and some follicular spongiosis.
Mm-hmm.
Those are findings of
Hmm.
I threw a Demodex into the equation.
Oh, rosacea.
Rosacea. In fact, there are findings of follicular rupture here, such as these hair shafts with caseous necrosis. Which is not as large as the previous thing we did, even though it's actually a little substantial. So what do we think about that?
This lupus miliaris.
Yeah, lupus miliaris disseminatus faciae, which is thought to be just a
Like form of rosacea.
yeah. What kind of form? Granulomatous form. Granulomatous rosacea, or lupus miliaris disseminatus faciae.
It doesn't look like it has that well circumscribed area though. Oh, I guess it kind of does in there. Yeah,
Here,
a little
here.
bit.
And
Yeah.
also, by the way, this area chucked out, as some caseous necrosis does. It also chucked out over here, see? So caseous necrosis can chuck out in the processing. It did
Yeah.
it in the last one, it did in this one. All right. A lot of infiltrate.
Yeah. A lot of lymphocytic infiltrate involving all levels of the dermis and some atrophy. I mean, looks like actually necrosis of the epidermis.
Yeah, some ulceration as well.
Yeah.
In this case, we have our diagnosis already. It's in the field abundantly.
Oh, leishmaniasis.
Yeah, it's leash. What's this sign called, by the way?
A marquee sign.
Marquee sign. Good. All right, so you know this is a what? A sort of
Yeah.
folliculitis. And let's say I told you that I stained this with gram and I found a bunch of gram-negative rods.
Gram negative. So like pseudomonas?
Yeah, so
Hot tub folliculitis?
hot tub folliculitis. Very good. What's the site?
Volar?
Volar. Okay. And what's the problem?
Little bugs in there. Pitted keratolysis.
Yeah. Pitted keratolysis. And what's the organism?
Corneobacterium.
I think it's a
Prior
family.
name is Corneobacterium minotosum, and the current name is
Hydococcus.
Hydococcus what?
Second
Yes.
Oh, Corneobacterium's not the name anymore?
No,
When did that change?
they changed it. I don't know why they do. There every once in a while they update these names.
What's the new name, Nick?
Chytococcus with a K, K-Y-T.
Hydococcus sedentarius.
I feel like I've never even seen that word. Okay, good to know.
Technically speaking, they could do either one on the
Yeah,
boards because
why I want to
it
know.
takes some time to update the question bank. So they could give you either one. If it's a new question, it'll be Chytococcus sedentarius. If it's an old question that's being reused, it'll be Corynebacterium. What's this?
Cartilage.
Cartilage. So we're probably on one of two sites,
Ear or nose?
ear or nose.
There seems to be a split in the somewhere.
Well, there's some artifact. There's collecting, but there's
Yeah,
a whole
that's
bunch of infiltrate.
it's artifact, yeah. Neutrophilic infiltrate.
Yeah, neutrophil. Well, so there's neutrophils here. There's a mixed infiltrate. There's also these.
Big cells. Oh, is this rhinoscleroma?
Yeah,
Those are Mikulitz cells.
those are McCulloch cells. Excellent. And we also have some other stuff, some other lovely stuff here. For example, we have what type of cell?
Plasma.
A plasma cell. And what is it bringing along?
Antibody.
What's this? What body does it have?
Looks like a Russell body, but I
A
don't know.
Russell body.
Um,
By the way, what is a Russell body?
isn't it like just a bunch of the immunoglobulin?
Yes.
Everything?
And if this were multiple myeloma with a bunch of immunoglobulins in it, we would call it something else.
Not sure.
A Dutcher body. Okay. Pseudoepitheliomatous hyperplasia.
Mm-hmm.
Neutrophils.
Wait, can I ask a kind of stupid question, Avi?
How do you know it's stupid?
Because I feel like I missed this probably like 7 months ago, but how can you tell the difference between pseudoepitheliomatous hyperplasia and just like regular hyperplasia of the epidermis?
That is not a stupid question at all.
Okay.
So pseudoepitheliomatous hyperplasia has been previously called pseudocarcinomatous hyperplasia. It almost looks like a cancer. The real challenge that people want to differentiate is not regular hyperplasia from pseudoepitheliomatous hyperplasia, but pseudoepitheliomatous hyperplasia from cancerous hyperplasia.
From like squamous cell.
Yes.
Yeah.
And there are ways of doing that, like, you'll, as you get, some people suggest that pseudoepitheliomatous hyperplasia is more pointy. There's less mitoses, even though you can see mitoses in reactive pseudoepitheliomatous hyperplasia. There's less architectural disorder. There's less pleomorphism among the nuclei. But this clearly looks different than, say, the hyperplasia you see in just psoriasis or a psoriasiform hyperplasia or a SEB. And you even see it here. It has a pointy appearance to it.
Yeah.
And it's in the context of a reactive process, in the context of a whole bunch of inflammation.
Mm-hmm.
Like you can see where the inflammation is. There's pseudoepitheliomatous hyperplasia, and when we get out of the inflammation, this might be a little bit of hyperplasia, but it's not.
It doesn't look as like angry and pointy.
Doesn't look like this.
Yeah.
Okay. So pseudoepitheliomatous hyperplasia with
Pus.
pus. Do we have a differential for that?
Yeah,
Okay, what's the differential?
here comes big green leafy vegetables.
What's that?
Uh, H here, Halogenoderma.
Uh-huh.
C is chromomycosis.
Chromo,
B blasto.
Basto.
G granuloma inguinale.
Yeah.
L leash. And I think V is like pemphigus vegetans.
I'm good vegetarians. Now, in this case, what kind of cell is this?
Ooh. Budding. It looks like two organisms budding together. Is this blasto? Wait, no. Hold on. Can you zoom a little more?
I'll force zoom it. Let's see.
No, it's one thing. It's not two things. Never mind.
One cell.
Yeah.
It has a nucleolus. Has abundant cytoplasm. It's probably a
Plasma
Yes.
cell.
No.
histiocyte.
Histiocyte.
Plasma cell would have a more of a, it has a
Yeah.
nucleus off-centric to the center with clock-based nuclei,
Eccentric.
nuclear Hoff. This just has
He
a
said it. He
nucleus.
was right.
Actually
nucleolus
see
there.
the little organisms inside
You
of it.
see the little organisms in there.
Yeah.
Look at them. They're inside the histiocyte. How soon can we do this? Let's see. So far, where are we at in our differential?
Yeah, like one of the two infections. So leash versus granuloma inguinale.
Okay.
And we know it's not leash because leash has the marquee sign.
Yeah.
And granuloma inguinale has the little safety pin inclusions, which this could be.
Yeah. Like this on higher power, these safety pins. So that's basically what this is. This is your nucleus, and these are your safety pins. Or if you don't like that one, here's this one. If you don't like that one, too bad, because the other one doesn't want to resubmit. All right. Anyway, yes. So these are the Donovan bodies. This is granuloma inguinale. Is there a Gren zone?
Yeah.
Yes.
There inflammation among, well, it's in a lot of places. It's actually a lot of places here.
Eccrine glands, fat.
Yeah. One thing I want you to be aware of is like this horizontal tracking, where it tracks along the level of, in this case, it's tracking along everything, but it's also tracking along the level of neurovascular bundles. And if we go into the fat, we see our old friend.
Um,
Oh, we got to be able to recognize these.
I'm blanking on what they're called, but I know what they're associated with.
What's inside them? Anyone know what they're called?
Oh my God, it's coming. It'll come to me in a
It's
second.
right at the tip of your, isn't that so annoying?
It's very annoying.
Right at the tip of your tongue, and you're like, oh my God, I just knew this.
Uh,
And you do know it, but
they're foamy.
it's the issue is a retrieval issue. It's not a knowledge issue.
This is globi?
Globi.
Bye.
These are globi.
I was on the right track with foamy.
Yeah. The bluish foamy.
Yeah.
Bluish bubbly foamy. What's the diagnosis?
Leprosy.
Promitus leprosy. What about this one?
Looks like a
Tuberculosis.
lavender sausage.
Yeah, also the tracking, right? So if it's not lepromatous leprosy, but it's tracking along neurovascular bundles, what infection hits the nerves?
So is this
So the-
neurovascular bundle tracking specific to leprosy?
It's one of the very few things are 100%, but
Yeah.
leprosy classically, the first thing it hits. In fact, what's one of the first symptoms of leprosy?
Oh, like neuro,
Yeah,
what's it called? Paresthesia.
paresthesias.
Yeah.
This is why. One of the first, it's neurotropic. It's a neurotropic infection. And because it's hard to see the nerves sometimes, nerves track along neurovascular bundles. And so what you get is this pattern where it's like, oh, our neurovascular bundle's at this level, and it's just this horizontal tracking.
Yeah.
And in this case, we have
granulomas.
granulomas that are dressed. So they're
Palisade.
tuberculoid granulomas. So this is
Tuberculoid leprosy.
tuberculoid leprosy. All right. Quite the infiltrate here.
Hmm.
Now, these histiocytes have a very eosinophilic cytoplasm, in case you
Mhm.
didn't notice. Hopefully you notice.
And there seem to be little, I guess, organisms.
There
Little
probably are
black,
organisms.
little
in there.
black dots.
Yeah, there's all sorts of dust going on here. There's lots of inflammation. I don't know if you may end up seeing these organisms. There's plasma cells here too. And the nuclei in some of these very um, very eosinophilic histiocytes are sometimes off to the side, like you'd expect in the plasma cell, but they're not plasma cells. But they have eccentric nuclei. There is another thing that we can see here. I'm trying to find a really good one. See how good we can find them. There are these bodies that are lamellated.
Is this crypto?
In Cryptococcus, you would
Sorry, not crypto, coccidio is what I meant.
in Coccidio, you would expect to find
I thought those like encapsulated bodies that you just circled kind of look like crypto. I mean, coccidio. No. Oh wait, no, I was thinking of crypto.
Yeah, you were thinking
Coccidio
of
is the bigger ones. I was thinking of crypto.
yeah. In crypto, the capsule is it's basically clear. It's a clear gelatinous capsule.
Got it. And that capsule that you showed us is dark.
Yeah. In fact, it's not even a capsule. It's just more of a lamellated concretion more than anything. And it has a basophilic tinge to it. There's a reason for that. They're here, they're there, they're everywhere. I'm trying to find a really classical one that they love to show. Let me see here. Oh. Yeah, so you have this so a very eosinophilic. Sometimes you can also see this basophilic stippling even outside of these bodies. That's another thing to be aware of here. You don't always have to find the basophilic tinge in the bodies, but there's a lot of them. You can see them here. And so what might have a bunch of histiocytes, a infiltrate, comprising neutrophils, plasma cells, very eosinophilic histiocytes, with eccentrically located nuclei, with these basophilic lamellated structures and occasional basophilic stippling outside of lamellated structures.
I want to say histo, but I feel like that's not right either.
What would you expect to see in histo?
Tiny organisms within the cells, within
Yeah.
macrophages, maybe?
Would that even explain the color of the histiocytes? Like,
No.
look at these. Here we go. Look at these eccentrically located nuclei over here in this really red eosinophilic histiocytes. This is a good field for that one, actually. It's not a good field for the bodies, but it's a good field for the histiocytes.
Could you give us a clinical hint?
Oh, no, I will not give you a clinical hint. This should be diagnostic at this point.
I don't know. I have no idea.
It should be. So they have a name. These histiocytes have a name to them. They're called von Hansmann cells.
Oh, Malacoplakia.
Malacoplakia. And if this is Malacoplakia, what are these bodies called?
Michaelis-Gutmann bodies.
Michaelis-Gutmann bodies.
Mm-hmm.
Very good. I still have not found the one true Michaelis-Gutmann body. The one, oh, except for now. Look, here's one that's actually not so bad. Look at that lamellated basophilic body over there. Oh, and this one too. Look at this one. Check this one out. See that? It's growing. They get like lamellated and lamellated. Has layers. This layer, this layer, this layer, this layer. What are they? And they stain for something, by the way. Michaelis-Gutmann bodies. What do they stand for? What's basophilic in H&E? What do we associate that with? Like basophilic stippling or
Like nucleic acid?
material?
PAS? PAS?
Oh, yeah, okay, that's a broad question. Think what mineral? Actually, actually no, I'm not gonna, so you think calcium, but actually in this case it's iron. These stain for iron, apparently. For whatever reason. So yeah, so know the von Hansmann cells. Again, the really good field for that was here. Or somewhere here. Here, yeah. So these are von Hansmann cells. Von Hansmann cells are histiocytes. They have an eosinophilic cytoplasm, and they can have an eccentrically located nucleus. See that? Eosinophilic cytoplasm, eccentrically located nucleus. In conjunction with your Michaelis-Gutmann bodies. And you got the diagnosis, Malacoplakia. All right, good job. That is all I have.
Thanks, Avi.
Thank you. All right, see you next time.